hold a child or other feeding techniques to enhance a child's feeding time, lab work, physical therapy, observing a child's sleeping habits. All of these are part of the assessment for failure to thrive, which is growth failure. Failure to obtain or use calories required for growth and development equals weight that falls below the 5th percentile. Primary cause is inadequate calorie intake. Also geriatric, we're going to be comparing both the infant and geriatric. Geriatric patients are frequently also have the condition of failure to thrive. In their case, they're experiencing multidimensional decline in physical functioning, weight loss, decreased appetite, undernutrition, dehydration, depression, cognitive and immune impairment. Most common cause, malnutrition. Etiology, inadequate calorie intake. For an infant, that would be incorrect formula preparation, neglect. For an adult, that would be maybe fad foods or not taking in what they need. For an infant, breastfeeding problems, inadequate absorption, excessive calorie expenditure. In an adult, older adult, they may have medications that cause anorexia. It can be caused by errors in metabolism in an infant, AIDS, neurological disease, cleft palate, esophageal reflux, feeding disorders. Typical changes in geriatric failure to thrive are changes in body composition, imbalance between energy, intake and demand, homeostatic dysregulation, neurological, psychological changes. End of life or beginning of life, you can have failure problems, a lot going on. End of life. It's kind of the thing with adults when they start having cognitive problems. How do they regress? You start going backwards, right? And the order of how you progress is how you regress as an adult. Risk factors for infants is deprived of mothering, 3 to 15 months of age. If parents or caregivers experience depression, substance abuse, mental retardation, psychoses, socially or emotionally isolated, lack of knowledge, like the person I saw who thought they couldn't belong for some reason. Other reasons are parents don't offer enough food, not responsive to hunger cues, don't soothe them. Poverty. In the geriatric adult, multiple chronic diseases, polypharmacy, sensory perception deficits, delirium, substance abuse, alcohol substituted for food, neglect to eat due to substance abuse, mental health disorders, especially depression, poverty, social isolation, widowhood, abandonment by friends and families. Prevention, educate caregivers about infants' dietary and nutritional needs. Home nursing visits, encourage parents to be a part of the plan. For the geriatric patient, review patients' medications, their appetite, their nutritional strategies, educate them on high calorie, nutritionally dense food, not empty, and encourage to eat small, frequent meals. Get them set up with a home delivery system, Meals on Wheels, or supplements like Ensure or Boost. Also, Carnation Instant Breakfast is a great supplement. Refer to support groups to help decrease the isolation. Case management with financial or transportation issues. Manifestations in the infant, persistent failure to eat adequately, no weight gain, maybe weight loss, no definitive underlying physical disorder that can be found, erratic sleeping patterns, irritability, difficult to soothe, below expected growth pattern and developmental delay, nutrition, failure to gain weight, malnourished, not growing normally, apathetic, withdrawn, poor eye contact. For geriatric, unintended weight loss, wasting, lack of appetite and energy, diminished physical activity, poor muscle tone, dry, scaly hair, slow, poor wound healing, bone joint pain, edema, and we show anemia, low albumin and low prealbumin levels, low cholesterol levels, frailty, wasted appearance, impaired physical ability, diminished cognitive function. Weight loss alone does not indicate geriatric failure to thrive. Collaboration, history and physical treatment. Treatment goals are provide adequate calorie and nutritional intake, promote normal growth and development, assist parents in developing feeding routines, assist parents in responding to infant cues. I have taken care of several babies that were difficult this way, and the parents have a really hard time with this because especially if it's the first baby, they feel like such a failure that I can't get my child to eat. I'm not a good parent. And sometimes it's not their fault. So good parent support is so important because if you can imagine holding your little baby and watching it waste away, and all it needs to do is eat, and you can't get it to eat. So you do feel that they lots of times feel like that they are not good parents, and they can send them into a depression as well. The aim is to reverse the cause of the growth failure. Diagnostic tests, height, weight measurements, history, family history, dietary history, the child's activity level, any food allergies, dietary restrictions. Assess the home environment for what's going on, see if there's anything that needs to be addressed. Physical examination, assess mealtime behaviors and rituals for the geriatric patient, odor belt, clinical assessment, nutritional assessment, different assessments you can use there for the elderly. Assessment of the BMI, psychosocial assessment, as well as diagnostic laboratory. Malnutrition screening tool, this is one example. Non-pharmacologic therapy in both, developmentally appropriate education for caregivers, home care visits. This is a time when home health visits referrals need to be made. Assessment of breastfeeding mom's knowledge, help her out with that if that's the issue. Improved oral intake of foods and fluids, smaller, manageable portions. Make sure the food is well nutrient dense with extra vitamins if needed. Softer foods if the problem is dental issues. Snacks, include the patient's choices on the menu. For critically ill, energy dense, high quality protein supplements, and enteral feeding if necessary. No medications are indicated really for primary treatment. Supplements such as vitamin D, B12. For older patient diagnosed with depression, treat the depression and closely monitor for any drug interactions. Surgery varies if they have cleft palate or some kind of obstruction that is obstructing and preventing them intaking or absorbing their food. nursing process, improve their nutritional intake, increase growth and height, teach parents, observe interactions, especially during feeding times, record height and weight, try to identify the underlying condition if there's an obvious cause and treat that. For older adult, acute care, chronic care for underlying disease processes, priority is to meet their nutritional needs. Referral to a dietitian, therapeutic communication for depressed, socially isolated, or coping with the loss of a spouse. Assessments, pretty much the same as we've been doing, their height and weight, their history, any unusual pregnancy, delivery issues in children, cues by both parent and child, as if something might be going on, behaviors such as rocking, singing, talking, body posture. Assessment of the older, assess for socializing. Food is a very socialized, something we socialize with. And if they're not socializing, they're isolated, it's going to affect their eating. Assess for food preparation. Do they have a place to prepare? Are they able to prepare? Remember, food insecurity, food deserts. Can the patient navigate the space? They may have an apartment, but if they're in a wheelchair or walker and can't get into the kitchen to do what they need, that may impede as well. Consider social services and meal delivery. Diagnosis,